Okay, so this is part 2 of the skeletal system. We're going to go through some of the pathologic conditions of the skeletal system, as well as a couple of the techniques and procedures to make diagnosis and treatment of the skeletal system. So one of the first disease processes that we'll look at is something called osteomalacia. And osteomalacia is, malacia means softening, and osteo means bone. So this is actually a condition where there's an abnormal softening of the bones, usually due to decreased calcium and phosphorus in the blood. Okay, both of those are necessary for the bone mineralization. We talked about how the bone is a primary storage unit for calcium. And so when we have a condition where we can't either absorb, if we don't get enough vitamin D, or we can't absorb the vitamin D when it's within us, called malabsorption, it can then lead to this softening of the bone. Okay, if this condition occurs in a child, it's called rickets, but if it's in an adult, it's called osteomalacia. And so once again, it's usually due to vitamin D, either deficiency or some sort of malabsorption syndrome, which leads to abnormal softening of the bone. Then we have osteomyelitis. So if we break this word apart, itis means inflammation of, osteo is the bone, and myelo refers to bone marrow. And so this is a condition where we actually get an infection in the bone marrow or the bone marrow of the bone. And when that happens, that means that the bacteria have a portal to actually get into the bone marrow. And so this is a very severe situation. And so this usually requires debridement, admission, debridement, and a tremendous amount of IV antibiotics. And so that's why it's very important if someone has a puncture wound, if it goes deep enough to hit the periosteum of the bone, a person needs to be evaluated, because osteomyelitis would be a risk for that. And generally, if an area were to start becoming infected, the skin around it would become red, and there could be pus coming from it, and the person would probably start to have fevers and excessive fatigue. And so any puncture wound or any injury that could get to the periosteum, this is a risk. Okay. Then we have osteoporosis. So osis is condition of, in this particular case, it's an abnormal condition. Osteo means bone, and poro refers to porous, or something that's got holes in it, basically. And so when we have osteoporosis, these are bones that at one point were strong, but what's happened is their density has gotten less, and so they become porous. This happens generally in postmenopausal women, but it can also happen in men as well. And so when we go through menopause, estrogen and progesterone drop. And so with those two hormones being less, we don't get as much osteoblastic activity occurring. So we get less calcium in the bone and more calcium in the serum. And so what happens is the bones become brittle and porous, which means they have a greater susceptibility to fracture. And we'll talk a little bit more about this as we go through as well. Treatment regimens for osteoporosis can be weight-bearing exercise, which is things like walking, running, or dancing. Okay, that does help increase that osteoblastic activity. Calcium, adequate vitamin D, stop smoking, decreasing caffeine and alcohol is also recommended for osteoporosis. And there are a number of medications that can be used, and some of them are in pill form, some of them are in injection form. They can actually help to increase the osteoblastic activity, actually help to start rebuild the bone a little bit. So this shows kind of just a timeline of what can happen when we have someone in their 40s, 20s, 30s, and 40s. We essentially have our normal hormone levels, and so we have our normal height, and we don't have any issues. But as we get older, we start hitting 60s and 70s. You can see how the lower or the upper thoracic spine starts to curve. We start getting impaction of these vertebrae. They start to collapse upon each other. And then over time, we can get this hunchback or humpback, or it's also called a dowager's hump, where we get this kyphosis or this curvature in the upper thoracic spine. And so taking heights of elderly geriatric patients is important because they will start to get shorter because these bones start to collapse upon each other, okay? And once again, it is more common in females, but we do sometimes, with decreased testosterone levels, we can see a similar thing happen in males at times. Okay, so question, osteoporosis, true or false? Osteoporosis and osteomalacia are describing the same problem, but one is more severe than the other. And so if we look back on those, slides, we'll realize that osteoporosis is a porous condition where the bone becomes brittle and easily fractured, to where osteomalacia is a softening due to lack of calcium and phosphorus within the bone. So one is softening and one is porotic, and so that is different. Okay, and so the osteoporotic bone is still mineralized, but it is weak and porous and less dense, to where the osteomalacia is demineralized, where we have lack of calcium and phosphorus within the bone. We have osteochondroma. So if we break this word apart, oma means tumor, osteo means bone, chondro refers to cartilage. So this is a benign tumor that can occur in the bone, and it is the most common one. The femur and the tibia is the most frequent area, although there's a few other areas that it can affect. There are a small percentage of these tumors that actually will become sarcomas. Sarcoma indicates a cancerous bone tumor, and so some of them will, but most of them stay non-cancerous, but they can still cause problems because they start within the bone and then they start causing sometimes even pathologic fractures. But it is, most of the time, it is benign, but once again, there is a small percentage that will become cancerous. We have something called Paget's disease, and Paget's disease is it's very rare, but when it occurs, it is very significant. It's a non-metabolic disease of the bone. It's also known as osteitis deformans, and it is characterized by an excessive amount of bone destruction. What happens is the body then tries to compensate, and the osteoblasts start laying down bone really quickly, and it's in an unorganized fashion. And so this bone tends to be weak and prone to fractures. There's something called a mosaic pattern that is characteristic of Paget's, and when you have someone that maybe has a pathologic fracture where they break the bone for no apparent reason, it just sort of fractures spontaneously, then they see a mosaic pattern on the x-ray. It would indicate that's kind of pathognomonic for Paget's disease. Okay, and so luckily it doesn't happen very often, but it can be very problematic when it does occur. Then we have Talipes equinovarus, and basically this is the technical term for clubfoot. And so clubfoot is actually something that occurs in utero, and it can be detected in utero. And what happens with the clubfoot is the foot becomes fixed in what's called plantar flexion, where it deviates, the toes deviate inward or medially, and then the heel is in sort of an elevated position. And I think we have a picture here. This kind of shows an example of clubfoot, and it can be detected in utero. So if people are getting proper prenatal care and they have their second trimester ultrasound, usually it can be visualized, and luckily there are surgical procedures that can be done that can help correct this. But obviously a child would not be able to walk in this case scenario, and so the surgery would have to be done in order to allow this baby or this child to walk. Then we can actually kind of take a look at our spine and realize that we have some abnormal curvatures of the spine. And the book talks about 3 specific ones on page 181. We have something called a kyphosis. And a kyphosis is sort of an outward curvature of the upper thoracic spine. Sometimes it's called a humpback, like the hunchback of Notre Dame. It's also called a dowager hump. And so we do frequently see these kyphotic curvatures with people that have osteoporosis. The vertebrae start to collapse upon each other. That individual will lose height, and you can start to see those vertebrae because of the becoming weak and and brittle and fragile, they will collapse upon each other. And then we have something called lordosis. Lordosis is actually involving the lumbar spine. Lordo means lumbar or loins, and so that's where that lumbar spine has more of an inward curvature. The other lay term for that is called swayback. And there are some normal case scenarios where this happens frequently in the late stages of pregnancy. Women will get a lordosis because they have so much weight with the baby being out in front. It will cause that lower back, which to curve inward a little bit more than it should, which is why women that are pregnant tend to have a lot of low back pain. It will reset itself after the baby is delivered, but there are some case scenarios where people have a lot of weight carriage in the front where you can actually see that inward curvature occur in someone who is not pregnant as well. Then we have scoliosis, which probably a lot of you have heard of. If any of you have had a physical exam done, especially when you were a teenager, there's a test where they reach over and have you bend at the waist and touch your toes, and then they look at your back, and that's actually a scoliosis exam. It's checking for a lateral or a sideward curve of the spine. That curve could be to the left or it could be to the right. But generally, when you bend over to touch your toes, if someone has it, you can usually see one scapula or one part of the back will rise a little higher than the other, and that can indicate that there's a problem with a lateral curvature of the thoracic spine. So this shows the three different curvatures here. A kind of shows the kyphosis, where you can see where that area starts to curve more in that upper thoracic spine area, like we saw in the osteoporotic patient. Down here we have this lumbar spine, and this can be normal. Sometimes some people are born with this, but once again, we can have, this lady isn't pregnant here, but this can be a normal variant that occurs with pregnancy or with someone that has some issues with abdominal obesity. Here we can see this. And then this letter C kind of shows us a right lateral curvature scoliosis here in that upper to mid thoracic area. And so these curvatures can be problematic, and sometimes if they're mild, treatment regimens for this would just be some physical therapy, loosening up the muscles, and maybe wearing some sort of a back brace. But some are severe, and they actually have to go in and put rods in there to straighten that out, because if this gets really bent, the more this is bent, the more of a problem it will be. And usually 12 to 13, when an individual, it's more common in females, and when you start going through puberty is when this starts to become a problem. Okay, so that kind of ends the curvature spot. Now we have some different kinds of fractures. So obviously there are case scenarios where the bones can break. And so the word for a broken bone is called a fracture. And there's a number of different kinds of ways to classify and denote fractures. And so the first classification is looking whether or not something is open or closed. And so an open fracture is where we actually have a break in the bone, but what happens is that bone penetrates through the skin and causes an open wound. Another word for this is called a compound fracture, as opposed to something that is closed. So we can have a break in the bone, but it doesn't cause an open wound in the skin. So a word for this would be a closed fracture or a simple fracture. So both of those terms mean that there was no wound in the skin from this particular fracture. Then we can actually look at the bone itself and say, is the fracture complete all the way through, or is it incomplete? And so when we have a complete fracture, that is a break that extends all the way through the entire thickness of the bone. And then we have an incomplete fracture where we have one side is broken or bent considerably, but not broken. One side is broken, but the other side is not. And so an example of that is called a green stick fracture. And we only see green stick fractures in pediatric patients because they haven't completely ossified their bones yet. So there's still a little bit more cartilage. And so if you can imagine holding a twig in both of your hands between your fingers and your thumbs, and if you were to push your thumbs up and the top part of the twig were to snap, but the underneath part where your thumbs doesn't actually fracture, it bends a little bit but doesn't fracture. That's what a green stick fracture is. And so that's a case scenario where the top fractures but the other part does not. And once again, we only see these green stick fractures in kids or in pediatric patients. Then we have a couple other types of fractures here. We have something called a compression fracture, and that's where a compression fracture is where the bone surface is being forced, one bone surface is being forced against another. And so we see these compression fractures in people that have osteoporosis where the vertebrae get pushed upon each other, and it's called a compression fracture. Then we have something called an impacted fracture, and this is where we get a direct force to a bone causes a break. And when we actually have a smaller bone becomes broken and it actually gets forced into the larger end of a bone, that's called an impacted fracture. So something maybe like in your lower leg, something from the side, if you were to break your fibula on the outside of your right leg, and then that fracture then, or that pressure then breaks the tibia, that would be an impacted fracture. And then a comminuted fracture is actually splintered or has different pieces. Comminuted fractures can be a twisting injury, but where you actually get a break in multiple areas where you actually get bone splinters. And those can be very difficult to deal with because those usually have to be repaired externally, where you go in and put a plate or put pins in order to get all of those splintered areas to re-adhere to the bone so that the bone can heal appropriately. Then we have something called a Colles fracture. Colles fracture has its own name because it happens a whole lot. It's actually a break in the lower, near the wrist, in the lower part of the radius, within an inch of the connecting bones with the wrist. And it occurs when a person goes to fall backwards or to the side, and then they outreach their hand or their arm to try to stop themselves from falling, and you get a Colles fracture. And once again, falls backwards, falls to the side are very common. You try to brace yourself, and then you break that wrist bone on the fall. Then we have something called a hairline fracture. A hairline fracture is also called a stress fracture, where you have a very minor fracture in the bone, and it doesn't cause any malalignment, because anytime you have a fracture, there's always a risk that the bone margins don't stay aligned. And so in this particular kind of fracture, it almost looks like there's a piece of hair on the bone. You're looking at the x-ray and you're like, oh, it looks like there's a piece of hair there. And so that fracture causes a little bit of a disruption, but both of the areas, both of the bone margins stay aligned. Okay. Then we have something called a pathologic fracture. This is where you actually get a bone fracture from pre-existing disease or weakness in the bone. And so it's generally from where a force that wouldn't normally break the bone actually causes it to happen. And so if somebody were to have a cancer growing in the bone, that could cause a break. If somebody has Paget's disease, then maybe just walking, it would break. So pathologic means there's some sort of disease process that allows or causes that fracture to occur, and usually the mechanism of action would not normally cause a fracture. Okay. And then obviously we have to treat these fractures, and so when we look at treatment regimens, obviously a lot of you have had a fracture, you might have had a cast on, but before you put the cast on, we have to get those bone margins realigned. We have to get both of the bone edges together. And so if someone has a closed reduction, that means that they can manually or externally reduce those bones and drive them back together and then put, the appropriate cast on that area. If something is splintered or very extensive, then they have to do an open reduction. And the book goes through a few of these kinds of treatment regimens, talking about the fractures, and they have to use certain internal devices like plates or pins, or external devices that put pressure that allow make sure that bone actually can grow and have that proper bone formation laid down so that it doesn't create a shorter bone. And so there's a number of different devices that can be done when we have extensive fractures. Okay, so a question. I jumped from a ledge and heard a crack in my shin. Ouch. X-rays showed that the broken ends of the bone were forced into each other, and this is called a what type of fracture? So we talked about when one bone, a smaller bone, was forced into a larger bone, that is considered an impacted fracture. Remember, green stick is where an incomplete fracture, where one side of the bone breaks and the other one doesn't, and comminuted is when we have splintered, some sort of a splintering fracture. Okay, so let's go through a couple of diagnostic techniques and treatments of the skeletal system. And so a bone scan. So a lot of people have heard about bone scans, and so this is where we inject like an IV radioisotope that is tagged, and it can be absorbed by bone tissue, and it usually takes about 3 hours for that to occur. And then you can pass a gamma scanner over, and then where you see areas of greater reabsorption, and that will be seen as dark areas on the bone as opposed to lighter areas, it can determine something called hotspots. And so we generally will use a bone scan when we are trying to detect the spread of cancer or metastases. If something starts in one area and metastasizes to the bone, you can get an idea of where that cancer has metastasized to. If someone has an osteomyelitis, that can show how far or how much that infection has traveled within that bone. And then it can also detect other destructive changes. Pathologic fractures as well are better evaluated with a bone scan versus just a straight x-ray. So once again, this bone scan can be used for a number of different purposes. So this just kind of gives you some of the increased uptake here. You can see these are darker, and this is an anterior view, so this is the front and this is the back. So you can see there's increased uptake in these areas, okay? Then we have something called a bone marrow aspiration. And so a bone marrow aspiration is where we actually go take a very large bore needle into a site and remove the bone marrow to take a look at it. And so the hip is the most common place, but you can actually use the front part of the tibia as well. And what that does is it evaluates the bone marrow, and usually when you're trying to diagnose neutropenia or acute leukemia or some sort of alteration in the bone marrow, that you can look at underneath the microscope and make the diagnosis of those things. And it is important that it is done sterilely, because since we are getting into the actual bone marrow area, we could very easily cause an osteomyelitis, so sterile technique is of the utmost importance. And the last one we have here is, this is a very common test done in primary care. It's called a DEXA scan. And a DEXA scan is the most common way that we actually diagnose osteoporosis. It's non-invasive. It's much easier to evaluate the bone density with this. It's called dual energy X-ray absorptometry. Everybody calls it a DEXA scan, though. These other two down here are not done very often. They cost more and they're not done very much, but this top one's important because it's very commonly done. So if women come in and they've had a high risk, if they're postmenopausal, if there's a family history of osteoporosis, if they fit the high risk factors for it, Asian and Caucasian females tend to be a little bit more risk. If they have low weight, if their BMIs are low, if they're smokers, those are all increased risks for this. And so the DEXA scan can actually determine whether or not someone is osteoporotic versus something which is an in-between stage called osteopenia. So penia means less than or lack of. And so if someone is on the way to developing osteoporosis but isn't there, this DEXA scan can actually take images of the femur and the vertebra, which are the two most common areas to see the osteoporotic changes, and that's what it primarily focuses on, but they can give you an exact score which says this patient is osteopenic versus osteoporosis, and it does determine the treatment regimen for each patient, because calcium and vitamin D are obviously important for postmenopausal females, as well as weight-bearing exercise, not smoking, minimal alcohol and caffeine, but there are some newer medications that can actually increase osteoblastic activity if someone is osteopenic versus osteoporosis. And so it does determine the treatment regimen for that individual. Okay. And I think there's one more question here, which I pretty much just answered, but it says the most common method to check for osteopenia and or osteoporosis is the DEXA scan, and obviously that is true. It is less time, emits less radiation, and is non-invasive, okay? So this part was a little shorter than the anatomy, but I wanted to separate this out in case someone wanted to focus in on one aspect or the other. So we'll go ahead and conclude here, and I'll see you next lecture.